Now I want to move on to Jakob, okay? And it's a similar, so these kind of rich social contexts, under pressure, different things where different responses are needed. Tell us about some of those experiences and how nutrition and health needs to fit into a much broader pattern or you won't get anywhere.
Thank you, John. Well, I would like to talk to you also as the president of the International Association for Ecology and Health. This is a movement that is based on the understanding that if we destroy our natural resources, we can never reach health. So we must do everything in the same time. We must sustain our own health, our animals' health, and the environmental health in the same time. This goes into systems dynamics, it goes into systemics. We have to break silos between our different disciplines. We have definitely to work together. That's why we work so much on the closer cooperation between doctors and veterinarians to solve some of these problems. So this is one answer to this multidimensional challenge. And I give you an example. First of all, we understand resilience very much as a socially layered process. You have resilience at the top level, at the government level. Now, for example, for the pastoralists we work with, some of the biggest problems are conflicts with crop farmers. Or they just have too many animals. So we need a new law. We need new legal frameworks that regulate how these people live together. This is resilience at the top level. And only based on that we can go deeper. And here, when you engage with communities, you will hear things you didn't expect, and you may not be able to respond. In Chad, for example, education of the kids was the absolute top priority, and UNICEF helped us to build up the first schools for nomads. In Mali, the Tamashek said, first of all, we want to have peace at the wells. When they are watering the animals, there are always conflicts. And then the second was a grain market, and only the third one, and I have to tell you how they said it. We want to have a place where we can put our head in the shade of the wind when we are sick. That was the very poetic way they asked for health services, but that came at point 3. And if we would plan a hospital in North Mali, it would never be used, never be used. These people are not used to sleep in houses. For them, it's a prison. So the solution is Africans for Africans. We cannot know that. These people, they know very well what they need. So, for example, also as signs of resilience, and that's also a bit in the answer of the lady from the USAID, we do this work since 16 years now. Now, last year, we had another stakeholder round, and we understood that now the government decides to have a directorate for pastoral health. The young community of the pastoralists, they are all communicating with cell phones. They have their social networks. And the most important use of these social networks is legal advice, because of their many, many conflicts they have, something we would never have expected. And the joint vaccinations, we thought that would be forgotten. No, they implemented, especially at places on border crossing. When the pastoralists go from Chad to Nigeria, they vaccinate all the cattle and all the kids. So it works at these strategic places where people and humans gather. Just with regard to your question about mobile health services, the problem is they are too expensive. So we have to find out new ways how to provide services, because just driving out with a car is just too expensive. Chad has $20 per head per year for health. You cannot do very much with that. Now let me just answer also to the question about antimicrobial resistance. This is again a systems issue. And here I would like to praise Canada. You will be most happy. Canada has introduced the Canadian Integrated Antimicrobial Resistance Surveillance Program, CIPARS. You can Google it once. And what they look at antimicrobial resistant strains in humans, in hospitals, but also in the food chain, in animals, in water, in the environment, and in this way they can identify the sources of this antimicrobial resistance. In this way they could eliminate a pressure for antimicrobial resistance from chicken production for human health, because they looked at it in a systemic way. And in this way I close the loop. We must become systemic. We must understand how the things are interrelated. We are at a point in science where reductionism is not problem solving anymore. We have to converge back again. We still need the specialists, but we need also the people who can interrelate these things.
Delia, do you want to say something about antimicrobial resistance? I doubt if you disagree with the systems part, but obviously some systems have less of an issue than others.
Well, and also to expand the question a bit, to one of the questions was asking for concrete examples of how resilience works and case studies showing about resilience. I think the message from the first part of my talk about the pandemics is that resilience only goes so far. And when you're talking about these low probability but very high impact events, which are very unlikely in any given year, but almost a sure thing over the long run, it's quite clear that what we're talking about resilience will not be very effective in managing it. If the temperature of the planet goes up 5 degrees in the next 50 years, we're going to see starvation, famine, accompanying plagues, that no matter how resilient we are. Ethiopia was one of the most resilient nations at the end of the 19th century with a long history, an amazing architecture, a well-developed system, but that broke down in the face of rinderpest, and that was almost inevitable. So the message there is it's not so much reacting to these rare but very important events, it's preventing them and trying to avoid them and see what we can do beforehand. And that takes us to the antimicrobial resistance, which is very much one of these absolutely civilization-altering events, if it were to occur. In Europe and America, not so long ago, 1 in 50 women died in childbirth. I mean, this had a profound effect on families, society, children dying in every family. We can't even imagine. That is the reality. People are still living in parts of the developing world. But it's hard for us to imagine that reality, and that is the reality we could go back to if the antibiotics we now rely on cease to work. There's two messages, though. I think the other thing about the antimicrobial resistance is we forget that the great decrease in human mortality and morbidity, which we've seen in the last transition, was only partially due to antibiotics. It really started well before the medical era and was mainly due to getting rich, getting hygiene, getting houses, getting all of these things. And those are the things, if we hit antimicrobial resistance now, it's clear that the people who are going to suffer most are going to be the people in the poor countries, and it's a globalized problem. It will go everywhere. Though I would say one small word of caution in terms of the One Health, Two Health. In America, more antibiotics are used in animals than are in people, and they're used for growing bigger, fatter animals and managing to keep animals in conditions which are not tolerated in some other countries. But if we look at Africa, the use of antibiotics in animals is absolutely minuscule compared to the use of antibiotics in people. And there's a total abuse of antibiotics in people. You can buy it on the side of the road, you go to the chemist, you get it anywhere. So I think sometimes it's too easy to blame the veterinary sector in Africa, and we should tackle the massive abuse of antimicrobials in human medicine, which is probably where most of the resistance is coming from, and then we need to start worrying about what to do with the livestock sector.
Okay. Now, I want to come to you, Anarud, and very much we talked about this huge problem, seems to be a preventable problem, where small shocks are driving people into poverty. And Harold's talked pretty passionately about the effects of targeting and really reaching out in equity. What are some of the solutions you can see to the, presumably this should be something that's solvable. It's not like it's antimicrobial resistance and we're completely gone, or some kind of pandemic we don't understand. These are all things we can do.
Okay, with your permission, John, I want to start with a little story. So, does anyone know the story of King Bruce's spider? I'm sure you do, right? So King Bruce was this guy, a Scottish king apparently. I might get some details wrong, so don't get me upset with me if you're British or English or Scottish or Robert the Bruce. So apparently he'd lost a few battles and was losing hope, and he was hiding out in this cave, and he saw this spider and it was trying to build a web on the roof of the cave. And every time it tried to build something, it fell. And then it went back and tried to build again, and it fell again. But it didn't give up. It kept going back, and finally it got the web built. And that brought home a lesson to Robert the Bruce, so he went back charged with greater resilience and fought back against his enemies, who I think were the English. Anyway, well, the point of this story, that the reason why this story occurred to me was when I was studying these hundreds of thousands of human examples of combating poverty or succumbing to it, is that human beings are naturally resilient. So what I found was that people who'd suffered a shock and fallen below a poverty threshold worked very hard to come out of it. But it was when they were hit by a second shock that their efforts, their self-reliant, resilient efforts to break out of the poverty trap were put to naught by a succession of shocks. And so the reason why I'm saying this is related to your question, Tiffany. Why is this related to resilience? Well, the occurrence of multiple shocks beyond your individual control, in my case health shocks, but also other kinds of shocks that the panel has talked about, goes counter to the resilient efforts that individuals and families and households make. And so in order to buttress their resilience, it's necessary to have systems in place at the community level, at the national level, at the international level, that can help people either prevent shocks better or deal with shocks better when they occur. Either this morning or was it yesterday, things are blurring in my mind by now, somebody asked, if you were to go to the minister of X and ask for the bottom dollar, what would you ask for? Well, I'm going to plug my favorite hobby horse and ask for health. And the reason why I plug health is because look around you, look at any country in the world that has single-digit poverty rates. It's not the United States with $50,000 per capita. It's countries at lower levels of per capita income and higher levels of per capita income. Not higher than the United States, but higher than Vietnam. But countries that have single-digit poverty rates have one thing in common. They have universally accessible, high-quality healthcare that individuals at any level of income can access. That's the one thing they have in common. And they have built these systems in different ways. In some cases, it's state-provided, what Americans would call socialized medicine. In other cases, it's insurance-funded medicine. In other cases, it's a combination of employer-funded and privately financed health plans. To me, the details of it doesn't matter so long as everybody has accessible health care. There'll be fewer people falling into poverty, and among those who fall into poverty, there'll be fewer who remain in poverty because of successive resilience-destroying